Hello, my name is Kelsie Brooks, and I'm a postdoctoral fellow in the Brunchley Lab in the Laboratory of Viral Diseases at the NIAID and NIH. And I'd like to thank the organizers for the opportunity for me to discuss my project today regarding SARS-CoV-2 infection and microbial translocation across the intestinal mucosa. Just as a brief bit of background, as I'm sure many of you are aware, pathogenic SIV infection and HIV infection in humans is associated with a loss of barrier integrity in the gut, particularly allowing microbial products such as LPS or bacteria to translocate across the barrier. And this is seen particularly in chronic infection and when individuals reach AIDS, as well as with resulting inflammation in products such as CD14 that's produced by monocytes and an LPS binding protein. However, this feature isn't restricted to chronic infections such as SIV and HIV. This has also been demonstrated in respiratory infections such as influenza, where mice that were infected with influenza A and then fed FITC did have a significantly higher amount that translocated across the gut, as well as a higher level of the intestinal fatty acid binding protein, or IFAB. And why we were interested in addressing microbial translocation in the context of SARS-CoV-2 is that, of course, COVID infection is often associated with GI symptoms such as nausea, vomiting, and diarrhea, with diarrhea reported in 30% or up to 34% of symptomatic cases. So we wanted to ask if intestinal barrier integrity is lost in SARS-CoV-2 infection, and whether microbial translocation could be contributing to the stomach inflammation that is also characteristic of symptomatic infections. To address these questions, we focused on both a rhesus macaque model of infection and human samples. And for our rhesus macaque model, we used a Washington 2020 strain of SARS-CoV-2 to infect both intranasally and intratracheally for upper and lower respiratory infection. We then sampled throughout the 10-day course of infection with nasal and throat swabs, as well as feces and blood. And we were fortunate to work with collaborators at Emory University for an additional series of animal samples from rhesus macaques likewise infected with Washington 2020. And lastly, we were able to investigate human infection with samples from collaborators at the Clinical Center of the NIH from time points at which individuals were recently hospitalized with COVID and then at their discharge when they had recovered from their symptoms. So the SARS-CoV-2 infection in rhesus macaques is not a highly pathogenic model for a healthy adult rhesus. We do see, however, that there is viral shedding of RNA in nasal swabs and throat swabs, with a peak at day 1 in the throat and about day 2 in the nasal swabs. And this was detected in all of the animals that we infected here at the NIH, although by day 10, the vast majority had cleared any virus or viral RNA. And again, this is not a highly pathogenic infection. The animals were not losing more than approximately 5% of their mass from baseline, and they were not having a fever as classified by temperature over 103. There were also not significant shifts in the microbial community, as determined by cysteine S sequencing and identification of phyla in the feces collected throughout infection. So despite this relatively mild to moderate disease, we do see some indication of microbial translocation in the colon of these animals. As you can see in this immunohistochemistry, from uninfected animals, there is really a minimal disruption to the barrier in terms of translocating bacteria, which you would see in white for E. coli, and that have crossed from the lumen into the lamina propria, as indicated here in a SARS-CoV-2 infected animal. And for uninfected animals versus SARS-CoV-2 infected, we see a modestly increased level of the clinical scoring of microbial translocation, although our SIV positive control demonstrates higher levels of microbial translocation. And this is also occurring while that there is viral RNA being shed into the feces as a comparison to the kinetics of the nasal and throat swabs and the viral RNA detected in those samples. The viral RNA detected in feces peaks about similarly to that in nasal swabs, with a day 2 high point, and then all animals, most of the animals having cleared viral RNA by the end of the 10-day infection. As a further indication of potential microbial translocation, there are reactive responses in the mesenteric lymph nodes of the SARS-CoV-2 infected animals, where the germinal centers make up a higher percentage of the total area of the mesenteric nodes than uninfected animals. And additionally, for IgG-positive B cells in the mesenteric nodes, there's a higher proportion of those cells that are Ki67 positive or proliferating than in uninfected animals. And lastly, we see a disparity in the systemic inflammation for human infections of moderate to severe disease requiring hospitalization versus infections in rhesus macaques. Humans experienced both significant decreases in soluble CD14 and IL-6 upon recovery from COVID, where in rhesus macaques there was only a significant increase for soluble CD14, whereas IL-6 was not detected throughout the infection, in contrast to SIV, where there is an induction of an IL-6 response. And just to summarize, we do see a relatively mild to moderate disease, but we have a nonetheless indication that there is a compromised gut barrier with microbial translocation in the colon is determined by immunohistochemistry, increases in soluble CD14 that can be produced from monocytes as a reaction to those bacterial products such as LPS. But this is in the context of a stable gut community, and there is viral shedding of RNA into the feces. So in a human infection, especially one requiring hospitalization, there's an indication that there is more inflammation potentially related to microbial translocation than there is in the relatively non-pathogenic rhesus macaque model. And what we're most interested in for going forward is determine whether or not the viral RNA that is being shed into the feces is indicating an ongoing viral replication, or if this is dead virus that is still generating an immune response. And we'll be investigating that by detecting subgenomic RNA that indicates viral replication in both fecal samples and tissues such as colon and liver and mesenteric nodes. And with that, I would like to thank all of our fantastic collaborators without whom we truly wouldn't have been able to carry out this work. And I thank you for your time, and I'm happy to take any questions.